Hello, everyone. We are joined by Dr. Katz in Boulder, Colorado, one of the leading chiropractors who has been researching upper cervical instability. And this is part two of a three-part series talking about craniocervical instability, upper cervical instability. And today we're going to talk about digital motion x-rays, which Dr. Katz is fantastic at doing, and he's really specialized in this area. And I'm hoping that we can talk today a bit about what a digital motion x-ray is, how to interpret it, and we're actually going to be looking at some of my personal scans and seeing what we can learn. So thanks for joining us again, Dr. Katz.
Thanks so much for having me.
So where do we begin? Why don't we just start high level, big picture? What is a digital motion x-ray and why is it so important for upper cervical instability?
Sure. Digital motion x-ray is basically x-ray taken at 30 frames a second. So instead of just having a still photo and a neutral or flexion or extension, we can watch the whole spine move. Why that's important is, why are movies important over just a Polaroid picture? Is a picture will tell, as we say, a picture could tell 1,000 words, and a movie a lot more, right? Because we can see not just what the bone looks like at the end range, but how does it get there? And we're also less likely to miss the instability or the problem or the pathology that you would typically miss on static imaging.
And so this is the same imaging that you were using for your research project, is that correct?
This is exactly, yeah, this was the exact machine that we did for the study on the injured versus non-injured, yeah. Yep.
Very cool. So what else should we know about digital motion x-rays before we take a peek at them? What's important for patients to know?
I think one of the main questions that we're asked is, does it have a lot of radiation? And the radiation is not that high. We do not even have to letter our walls. It shoots really fast. So we can't, there are some docs that say, oh, we could do lumbar spines. And I don't think you really can unless the person's really tiny, because it doesn't shoot out a lot of x-ray. It's great for the neck, jaws, extremities. But so that's one question that we're asked a lot. And we do have the actual numbers. And I want to say, don't quote me exactly, but about 2 or 3 minutes in front of the machine is equivalent to just getting 7 regular neck x-rays. And instead of having 7 x-rays, you get 30 frames a second for, let's say 3 minutes. What is that, like 900 x-rays? So you're getting a lot more data for really no more x-ray exposure.
So not as big of a risk as, say, a CT scan or chewing on uranium.
Yeah, exactly. And the thing is, everything has, to a degree, a pro and a con. And the low radiation, I mean, you can argue that maybe there's some risk to it, but I also think the risk of having these instabilities, especially upper cervical instability, and having it go miss or underdiagnosed for a really long time, I think is way worse. As you get poked and prodded and all these other things, medicated without a proper diagnosis.
So how do you diagnose upper cervical instability with a digital motion x-ray? What are you looking for?
So we're looking for a number of things, and I'll show you. I'm gonna try to share my screen here, and hopefully this works well. So you'll just hopefully let me know. Let me try this. Can you see my screen?
It's loading. There we go. Yes.
Can you see the whole video?
I can, yes.
Okay. So this is what a DMX looks like, and we'll just kind of go through little tidbits of it. And when we play it, like, that's a regular x-ray, right? I know when I pause it, it gets a little fuzzy on the bottom. But what we look for is we have the person move, right? So we do a number of different movements, flexion and extension. We'll even do, and I'll speed this up, we'll even do nodding motion. So for the upper cervical, we can look here. We also look at the skull base angle. So we're looking to see some of the ligaments, could be a little bit of the alar ligaments. There's a new ligament that's in the research about the superficial anterior lanal occipital ligament. And we can start to look, just how does this move? What does it look like when it moves? How does the spine respond? We start to also look at, obviously, the lower cervical spine. We look at the shape, and then we'll measure all these angles, and we'll get to your image here soon. We look at all these angles of the backs of the vertebral bodies. We can look at what's called spinous process fanning. But then one of the things we found in the study as well is we also looked at something called spinous process engagement and how these bones move together. Like one of the things that we see is when someone extends, there should be better extension here, and it shouldn't be pushed with the back of the skull. So if we just pause that, that looks like a normal extension. But I'll rewind it. If the, on you look up, all the extension occurs here and nothing here. And that could be a sign of potential, cervical instability. Then we do a bunch of other views. I'm going to fast forward here where we look at the facet joints. We look to see if there's what's called facet gapping, all these other, factors that we looked for, like this would be considered some facet gapping, looking to see if the facet capsules are torn. We also look at spinous process rotation, these little bumps, and we want to see them rotate, which yours down here do. And then I'm going to fast forward just the upper cervical for, time wise. And now here's the upper cervical spine, right? So if I pause it, this is C1, and this is the edge of C1. This is the dens of C2. So we're looking through the mouth. And then this is C2. This border and this border should not translate over by it shouldn't go more than about 3 or 4 millimeters. So you'll see as you start to tilt, and let's say we're going to get you in a better position, or let's say I'll go back here. You could see the edge here and the edge here. And then we look to see how much space. The other thing we're looking at is we talked about in series 1 about that periodontal space. We measure this and this and this to this. So on you could see how much lateral translation you have here. You could see how wide this space gets, which is both from translation and rotation. And then we'll go to the other side. We also look at the spinous process rotation that we'll measure. And then we'll measure this as well and look to see if you have bilateral upper cervical instability, and then we'll measure here as well. So if we go to, let's say, I'm going to try to get out of here for a sec. And then if we go to the images that we do from our office, they'll look something like this. Let's see. All right, so we give this big report, and then this one we'll do, here's a normal neck. Can you still see my screen okay?
Yes, I can see. Yeah, I can see the PDF.
Yeah, we compare the curve, which you can get from a lateral X-ray. That abnormal curve is a problem. And then we start to measure. And you'll see I put in all these little measurements off of our paper. How much movement should occur. The red lines are established normals for instability. And then here we start, we measured on you. You had 7 millimeters of periodontal space, 2 on this side. And then we measure how far it translates. And you can see on yours was, 4 and 5 millimeters, which is way in the instability. And of course we measured your facets and so on and so forth.
So this is a very manual process. You have to look at every image, get the right snapshot. It's not automated, right?
No, it's not. So it's me, me or Shauna, my wife, the other doc, we shoot the films, we sit down, we watch it, and we measure it. And that's the thing that you get with our office really is, since doing that study, we really know what we're looking at to say, I'm going to put an arrow here because this was something we found in our paper. And we know that this is a potential abnormality.
Absolutely.
It's a long process.
Yeah. It's good work though. It's important work.
Yeah, thanks. So that's how we start to establish if there's instability at not just the upper cervical spine, but the rest of the spine as well. So you can not just get your upper cervical spine treated, but you get the rest of it treated as well if there's issues, and look to see how they all correlate and work together from a mechanical perspective.
So you were talking about the periodontal space and then also the overhang. So for the layman, can you go through those concepts again and how you would see them on a DMX and why they're important and what the other indicators might be of upper cervical instability?
Sure. So can I get back to this? Let me see here. Oops, maybe I lost it. I'll pull it back up. So you want to see like some, I'll show you a couple of, I guess it doesn't even have to be your video. So I'll pull up a couple of crazy images here. let's just see. Oh, 1 sec. And I'll show just a couple of like translations and some other really weird, interesting things that we have seen. Let's see here. So here's a C1 translation, and I'll show you on this. So this is just a little snippet picture that I picked, and you can see how it starts to translate over, right? So you'll see here's the edge. This person had a lot. Here's the edge. Here's the edge. So we're looking at the edge of C1 as it relates to the edge of C2. And here's the dens, and here's that gigantic space and how it narrows here. So it's looking to see how much of a space and a gap that there actually is. Like that this person had a real lot. Now, can you see me on here or not yet? You just see my screen.
I can see your screen and I can see you.
You can see me? Okay, so this is, right, here's a model of C1 and C2. And if we look down, you can see this is where the canal is, the brainstem is, that's the dens, part of C2, and these are the ligaments.
Mm-hmm.
Yeah, so what we're doing, if we're looking at it through the mouth like this, when the person tilts, we're looking to see if C1 here shifts to this side. And then we're going to measure the edge of C1 to the edge of C2, looking to see if it, makes a significant difference. And then if it does, then we measure it. And the same thing from the periodontal space, we're looking at where does that den sit relative to the inside of C1 and how much shifting there is here. And again, from the paper, here, these are the stats from the paper where we're looking at C1 overhang and periodontal space, and look at how prevalent it is in injured patients and how it almost doesn't exist only 3% of the time in the asymptomatic population. But we don't know that unless we actually measure it, look at it, and pause it in the right position compared to just a static image.
So can you tell us a little bit about the ligaments that could be causing the instability? Are these ligaments that would connect to the dens, or are they connected all over the place?
They'll connect to the dens, like the alar ligaments are called, they're also known as the check ligaments, and they go from the tip of the dens to the skull base. And then you have the alar ligaments and the transverse ligaments that can attach from C1 to C2 and around from C1 to C2, acting as a seatbelt to look to see if it translates from one side. So if we, I'll show you a pretty, if we look on, it won't be on your image, but if we look at what's called an ADI space, we can look to see if C1 really opens up. And that's another measurement that could be, let me just see what I have here, because we've seen some really horrible, crazy things that have gone, I'll show you this here. So what we're looking at is now from the side, and this is, pause it. So now we're looking at, this is the back or the front of C2. This is the front of C1. This space is really large already, but you'll see when this person looks down, and this is massive. She moved a lot. How much this opens up and how much it closes. This person's moving a lot. I'll slow it down. And you'll see how much instability this poor person had. Like this space is gigantic.
Yes.
And yeah, that's almost a surgical case just from that alone. Let's see. And she was younger, so she moved pretty fast. But we see stuff like this. Let's say, here's another one that we'll show. And this again, we're looking at, so you'll see how big that space is there?
Yes.
What closes, right? So that looks normal, but then look at that, all that space. So if we look at that this space should not be more than 3.5 millimeters. And it should
How much is that, you think?
I think on this person, it was a little over 5. And that signifies, transverse ligament injury. Which is upper cervical instability, around the craniocervical junction. It's not just that lateral bend. It's not just grab oaks in normal position. It's looking at all of it. You know, what does the transverse ligament do? What does the periodontal space do? What does the lateral translation do during what phase of movement? And also what's happening with the skull base throughout the movement. All those things you can't see unless you either get it at the exact right position and hope you're lucky, or you do an actual motion study.
So you can't see the ligaments on the X-ray, though, correct? You have to
Correct.
wait for the bones, and you have to sort of interpret. So
Yep.
it's still somewhat difficult to know exactly which ligament could potentially be disrupted. Is that true?
So on the DMX, on a lot of MRIs too, you might see, so on the DMX, you're not going to see the ligaments. You're going to see abnormal movement based on what ligament should be holding it in place. So that's when you can say, you know, okay, like for instance, on that one I showed you with the ADI space, you know that's a transverse ligament because that's the job of that ligament. Same thing if you were to grab, you know, someone who tore their ACL and move their knee and it slides, you're going to know if it's the ACL or the PCL based on how much movement is occurring throughout that range of motion. So you can't see the ligament in the video, and a lot of times on MRI, I always explain it like, just because you see a seatbelt on somebody, you can't tell if the seatbelt is locked or if it lost its elasticity.
Mm-hmm.
You have to move to see how well is that seatbelt holding you in place. So a lot of times in MRI, you can see a ligament that looks intact, but at end range, it's just overstretched. So it's just like a rubber band that lost, and now you're unstable. So for us, does it really matter if the ligament is overstretched or torn? Like, do you need that confirmation on imaging? Not always. You need to know, is that bone stable?
Absolutely. So one of the questions that came up in the Regenix Facebook group is, I can't get to Boulder easily, really hard, or I live in a country where I'm lucky to even have a DMX machine within 500 miles of me. But we know that not all DMX scans are created equally, and sometimes they
Right.
really stink, and Regenix will just throw them out and say, sorry, go to Dr. Katz. What can
Right.
patients do to increase the likelihood of having a successful DMX with their local provider, if anything?
I mean, they can, you know, they can reach out to us and see if we know somebody, you know, and that's hard because we don't know if the, you know, if the doc or the tech is paying really good attention. We don't know if they're going to measure it. Like, we've seen some measuring program softwares where they're awful, and it's like the image might be good, but the measuring is terrible, or they don't do most of the measuring, and that doesn't help. That's a tough one, you know, because sometimes we see where, you know, we've had patients come in like, oh, I have a DMX, and we look at it and it's not even a full scan. They leave out like 50% of the movements. You're like, this doesn't even show it all. Or it's, so I don't know. I don't know what the answer is. I mean, they could always try to reach out to us and we can look to see if, you know, if we know the person or where they are, if we know someone to do a good job. You know, so that, you know, that's tough.
What's the number one thing that gets messed up on DMX scans?
I think the quality, you know, like it's just not diagnostic. They do it too fast. They don't have the calibration correct. And then, you know, and then what we've also seen, like I said, I think the second thing from there, outside of like not measuring it, is they just don't do the full test. They don't do all the movements.
Absolutely. Well, is there anything else that you'd like to add to the mix here with respect to DMX scans?
Um, no, I don't know. Do you think we covered that?
I think, well, we went through a lot of content. I know you're a
Yeah.
busy dude. I don't want to take up your whole evening.
No, if you have more questions, fire away. You know, did anyone else ask any other questions that, you know, that they want answered?
So tomorrow we're going to have probably a quite lengthy Q&A session. So I'm going to be organizing those questions tonight and then sending, well, tonight, tomorrow, and sending them over to you. There are
Okay.
some DMX questions in there, but there's a
Cool.
whole bunch of juicy questions. I think you'll find it very exciting.
Okay. Should we, you know, and I don't know if you want to edit this, but do you want to just see if you could do it live on their site tomorrow on Thursday night?
Let me check in with Daniel and see if that's possible.
I don't know if that's better for you or not, but whatever works. Or we could just, eh, answer it and throw it out there.
Yeah, let me check in with him. It might be hard to coordinate last second,
Right.
but let me check in.
Maybe it's better to do it this way, but yeah. So yeah, so send me the questions because I'll look at it, and then on Thursday we'll do it again and we'll look to see what the Q&A is.
Yeah, very good. All right. Well, thank you, Dr. Katz.
Yeah, my pleasure, man. I appreciate it. I'll see you on Thursday night.
Sounds good.